Okay. Great. Well, I'd like to thank the National Academies for inviting me here today. I'm sorry I couldn't be there in person. I think I agree with a lot of what has been said thus far, and so I may skip over some of my slides just to highlight a few points that may have been not mentioned. Just to share with you my practice situation, I work at Stanford Pain, and we have the privilege of working with a orofacial board certified dentist. We have 4 or 5 pain psychologists in our clinic, depending on the time. We have anesthesiologists, physiatrists, and physical therapists as well. So we truly have a multidisciplinary clinic, and it really allows us to evaluate the patients and treat them. And I'm not going to speak about the joint disorders per se. So what we focus more on is pain, basically. And so people come to me and come to our center more from temporomandibular disorders, from the myofascial on, and sometimes they come after they have already had their surgeries and are still having pain. But we're going to focus mostly on the temporomandibular disorders this morning. So the major challenges in care from my perspective is, I'm going to touch on each of these briefly, is that I just feel that there is a lack of orofacial pain recognition, especially on the dental side. And I think this has already been touched on yesterday by Dr. Frickton. Hopefully I'm pronouncing his name right, but I'll just go over that briefly. Interdisciplinary recognition on both parts of on both the dentistry side and the MD side. I see the patient in the context of the larger picture, the chronic pain patient. When I see that patient, those shaded diagrams that Dr. Chen just showed us, I see a patient who needs much more care than just focusing on the temporal mandibular joint. They need a pain plan to get all of their multiple pain syndromes under better control. And I think that we need to recognize that patient and triage that patient more effectively. And I think that as a field, we really need to improve the specificity of our diagnostic criteria, and this will hopefully help lead us to an understanding of better disease and treatment pathways. And finally, I hope that will lead to an improvement of ICD-10 codes. And that that coding will allow us to more successfully authorize and get approval for particular patients to be seen for specific indications. So in terms of orofacial pain recognition, the Council, I think we have discussed this already, but the Council for Affordable Quality Healthcare doesn't recognize orofacial pain as a subspecialty of dentistry. And this council has become an important council because it's a major pathway for dental providers to register and get accreditation, which is viewable to insurance companies. And so, the CAC says that this leads to that they don't recognize orofacial pain as a subspecialty because the ADA doesn't recognize orofacial pain as a subspecialty. And I don't know what the right answer is, but I think that ultimately this leads to very poor care, and that orofacial pain as a dentistry subspecialty really deserves a place at the table. There are other stakeholders, and we're going to come back to those, maybe stakeholders that we haven't discussed in a few minutes. But as we have sort of alluded to, the American Academy of Orofacial Pain, the International Headache Society, the International Association for Study of Pain, these people also are extremely interested in the study of and the care of these patients. Why is interdisciplinary care so important, and why is it so important that we recognize these patients? I think many people that are sitting at this table know this answer and have done these studies, and so they know this much better than I do. But I see it every day. The patient that is just being treated with some topical diclofenac for their jaw pain also has migraine headaches and cervicalgia and possibly fibromyalgia. And so it is very important to understand the chronic overlapping pain conditions that these patients suffer from and to get them the care that they need. And that's what we do in a multidisciplinary clinic or an interdisciplinary clinic. And to also get them the psychological care that they need. And while dentists may be able to understand the types of localized therapies that they need, getting these patients to a catastrophization class or to work with a cognitive behavioral therapy class to work on reducing their negative affect and somatization is really an incredibly important part of their therapy plan. Again, not for patients like Adriana, this is totally different, but these are patients that are more like what Dr. Hong Chen was speaking about, the patient that has the entire body shaded in when they come into your clinic. What would make my practice life much easier is if I had more diagnostic precision. So currently, the DCTMD published by Schiffman in 2014 lists the major pain diagnoses as arthralgia, and that is and then different permutations of myalgia. So myalgia, and then with some radiation, local myalgia, a little bit more radiation, myofascial pain, and it goes all the way up to headache. And that is sort of, I kind of see that as basically very superficial. And I think that we need to go much deeper as a field and really get into the weeds of these diagnoses and better define them and better differentiate them, and then that will help us develop better treatment pathways. And to that effect, recently this year, the international a consortium has come together to form the International Classification of Orofacial Pain, and it was written and proposed by representatives from these 4 societies, and it's modeled after the International Classification of Headache Disorders. And I'm not sure if you guys are familiar with this, but this is a very thorough body of work that is in its currently 3rd version, that is an international classification system for all headache disorders. And it's used by researchers, it's used by clinicians, it's used by lay people to help them better understand their disease process. And it's constantly revamped based on the opinions of researchers and clinicians, and it has become a very valuable document for moving headache research forward and headache treatment forward. And I think that the same can be done for temporal mandibular disorders. And so in this International Classification of Orofacial Pain, they subdivide primary myofascial pain. They subdivide they subdivide myofascial pain into primary and secondary, and then you can see the multiple etiologies below. They also do the same thing with arthralgias. They do the same thing with nerve disorders. And then finally, they actually have a new category of orofacial pain resembling presentations of primary headaches, which for me is fascinating. And I see these cases all the time, and I have never been able to fit them into a category. So it's interesting for me as a practitioner to know that there are other people out there that are seeing similar patterns and pain representations and putting names to them, because again, that leads us down different pathways. I would treat a patient with orofacial migraine much different than I will treat a patient who has primary myofascial pain. And so that hopefully will lead us to the point where we can refine the ICD-10 code and kind of branch off, and where temporal mandibular joint disorders will have a more orthopedic realm that fits the needs of the oromaxillofacial surgeons, and then a more specific pain and pain process realm that fits the needs of pain providers and allows us to go down different trajectories and allows insurance companies to understand why we are attempting to get the services we need for our patients. And I think that covers all my major points. Thank you guys very much. Appreciate it, the opportunity to speak.